Hi, this is Ramadoss, and welcome to the colorectal screening information. As you all know, this is a colon cancer month. March is a colon cancer month and a blue color. So we have the pleasure of having Dr. Anderson, the gastroenterologist from Gastrointestinal Associates. I'm from Missouri Cancer Associates. We put together a up-to-date information on the colorectal screening. I hope you found it useful. And if you have any questions, we will talk at the, you can mail us or we can talk to you guys. So colon cancer, why is it no important to screen for colon cancer? So idea is that if you detect a polyp early and remove the polyp, then we can stop the colon cancer from happening. So either you find it in the colon or rectum, and so we can stop the cancer from happening in people. And detecting polyps is the goal of screening. However, like you can also find cancer, like when you go for a screening colonoscopy. And also, if somebody is anemic, if you are ordering a colonoscopy, then it is not a screening colonoscopy. Make sure like you order as a diagnostic colonoscopy. So that would be important. So what is the scope of the problem? This is a leading cause of cancer-related death in United States next to lung cancer. So that's why it's important to identify the colon cancer at the early stage so that we can prevent the death of the people. So the average lifetime risk of getting colon cancer is about 1 in 20 in the lifetime. And almost 90% of the cancers occur in people older than 50. And so there has been a recent recommendation in change the starting age for the screening for colonoscopies. Recently, we will talk about it and the importance of that. And if you have multiple patients with the multiple family members with a colon cancer, the risk of developing cancer goes really high. You really want to catch those individuals and start screening them at the appropriate age group. And the colon cancer, since it's a curable disease, like almost like stage 1, 2, and 3 patients in majority of them. So there are more than 1 million survivors in the country at this time because of this screening effort. When it comes to Missouri, like the rates per 100,000 in non-Hispanic white males is about 47.6, and the mortality is 17.3 per 100,000 people. For women, it is slightly less. That could be a result of protective estrogen in colon cancer, for prevention of colon cancer. And non-Hispanic, Black, and men, as well as in women, have a higher incidence of colon cancer, and their mortality is also high. So it's very important we screen those individuals also for the prevention of death in this group. And as far as we talked about this, second leading cancer death in the United States and third most common cancer in men and women in the United States. And estimated nearly 150,000 people with diagnosis of colon cancer, and almost a third of them unfortunately will not live very long after the diagnosis. So if you break down by the age groups, and under 49, so almost 18,000 people will have the colon cancer. Like of these colon cancer patients, like if you higher keep the incidence keeps going higher like as they get older. And if you look at the death rate, also goes higher as they get older also. And so what are the risk factors for colorectal cancer? The common, most common risk factors associated with increased red meat and saturated fats, obesity, physical inactivity, smoking, ethanol consumption, and gut microbiome is catching up, and diabetes, and also the family history of colon polyps, Lynch syndrome, and the familial adenomatous polyp syndromes. So next few slides, I'm putting down the what are the relative risk of getting cancer in the with the different risk categories. So if you have one person, one other relative has a colon cancer, your risk of getting relative risk goes up by 2.2 times more than the average risk. So if you have like, anybody under the age of 50, then the increase is almost 3 times the risk. And more than two family members, the risk is even goes higher. And if you have second degree relatives, like, yeah, that also counts. And as a higher risk. And those who have inflammatory bowel disease, it's a 1.5 times the risk compared to the people without the inflammatory bowel disease. And type 2 diabetes in male predisposes, in female, it is not statistically significant, but slightly on the trend of the higher risk. So the modifiable risk factors are alcohol use, obesity, and red meat consumption, and then processed meat consumption, smoking versus not smoking. And the factors that decrease the risk for colon cancer would be physical activity and decreased dairy consumption. Those would be a couple of risk reduction factors that you can take. So as far as the hereditary colorectal syndromes, we have the hereditary non-polypoid like colon cancer syndromes. These are the common gene mutations associated with that. And if they have like some of the any of this mutation, the most common cancer would be colorectal cancer, and the second cancer would be endometrial cancer in women. And they are also at a high risk for other cancers such as stomach, ovarian, and bladder, and urinary tract and kidney cancers. And so that's the Lynch syndrome category, the familial adenomatous polyposis syndrome. So they, this is these two diseases, like all these three diseases are autosomal dominant diseases. And those with the familial adenomatous polyposis, they will have more than 100 polyps generally, and they can have polyps anywhere in the GI tract, including upper and lower GI tracts. And also they will have some extra colonic factor features also. And then there is a attenuated variety of that, and they have less than 100 polyps. And then you have the MOH polyposis syndrome. This is a recessive disorder, and they also resemble like a familial adenomatous polyposis syndrome. This is a risk factor, or the lifetime risk of getting different cancer in the people with the Lynch syndrome. So if you look at it, like most of the people with the Lynch syndrome, compared to the 4.5% of risk for getting the colon cancer in general population, almost 80% of these people will get colon cancer, and women, like about 60% of them will get endometrial cancer and ovarian cancer, and the other cancers like we mentioned in the bottom line. So how do we suspect somebody has this hereditary syndromes? Those individuals with more than 10 colorectal polyps, those individual with a first degree or a second degree relative with more than 10 colorectal polyps, and those with a diagnosis of colorectal cancer under the age of 50, and those who have a first degree relative under the age of 50 with the colon cancer, or anybody more than first degree relatives or some second degree relatives, Lynch syndrome. So you need to screen them. And anybody has a endometrial cancer under the age of 50, you can screen them. We do have a genetic counselor in our on-site, and so she's very trained to do the screening for all these familial syndromes. And so what are the current recommendations until like the October of last year? Like anybody who over the age of 50 to 75, you can start screening them. That used to be the guideline. And after the age of 76, if the life expectancy and depending upon their overall health, you decide how often you need to screen. And those would be for the age group of 76 to 85. And you want to consider their overall performance status and their life expectancy, then you can make a decision on that. In last year, around September or October, the US PSTF, which is the body which puts up the cancer screening guidelines, they are recommending starting the screening at the age of 45 because of increasing incidence of colon cancer in the age group between 45 to 50. And this is in alignment with the American Cancer Society also, which is recommending starting the age of 50 years of age. So if you cut down the screening to start at 45, then you will have a lot more people immediately eligible for screening. I don't think we have enough gastroenterologists to do all these people getting screened quickly. So you probably want to factor in their family history of polyps or cancer or endometrial cancer. You want to risk, and then also if you see them like in the category for a higher risk, you probably want to screen those individuals. But we need to offer it to pretty much everybody. Uh, uh, Anybody who has the average risk can start getting colonoscopy at 45. If you have some high risk people, you really want to get them started at this age. So, this is from 45 to 49, there is a increased risk 2% per year in this population. And 1 in 10 people are getting diagnosed with the colorectal cancer under the age of 50. This recommendation means the insurance will start covering these people at an earlier age. And so that would be helpful when they make this recommendation by this. So by 2030, under the age of 50, the colon cancer incidence will go up to almost 90% up. And also, if you look at the rectal cancer, the incidence is going to be even go up much higher to 125%. So that is the why they started recommending the screening at an earlier age for this group at this time. And this is the summary slide. So, the only change in this would be you have the categorization of average risk, increased risk people, and high risk people. And the screening for the hereditary syndromes are different. So you probably want to look at this slide at some point and then start screening them appropriately. And so I'll turn it over to Dr. Brad Anderson. He will talk about the different modalities of colon cancer screening and advantages and disadvantages of the screening procedures. Brad, thank you.
Yeah, thank you very much. It's great being here and being able to talk about this. This is a topic that obviously means a lot to me professionally, but also means a lot to me personally too. I lost my father-in-law, who was a Boone-affiliated physician, to colon cancer about 7 years ago, and that really inspires me to do better for my patients when it comes to screening as well. So we're going to keep things fairly low level. We won't get too far into the weeds in terms of some of the specifics unless there are questions and things afterwards, and then I'm happy to field questions as we go. But without further ado, I like to just start with this slide because it gives you an overview of some of the changes that we make in terms of the intervals that we will select based upon what we find during the procedure. So if somebody otherwise has a normal colonoscopy and their average risk, meaning that they do not have a family history of colon cancer, then every 10 years is when we typically will continue with surveillance. However, if we do find adenomas or precancerous polyps, it depends on the number that we find, as well as if there's any advanced features, meaning if there's any villus component to the histology, or sometimes even the way in which we resect these polyps will then dictate when we need to bring somebody back, and we favor bringing them back sooner rather than later in those settings. But there's a lot of data behind these intervals, and that changes, almost on a biannual basis, just in terms of the literature that we have. And so this is it morphs as time goes along, but this has been a fairly standard screening approach in terms of intervals for some time now. Just in terms of an overview of screening options, we like to break them down into stool-based tests as well as direct visualization tests. Amongst the stool-based tests, we have the guaiac, or the fecal occult blood tests, which are generally offered every year. We have the fecal immunohistochemical testing, or the FIT test, which is also an annual screening modality. And then we have the FIT DNA test, or the multi-target DNA test, also goes by Cologuard, which is what most people are familiar with from commercials, and that's offered every 3 years as a modality. And then for the direct visualization, everybody's going to be familiar with colonoscopy, which we reviewed. As long as things are normal and you're of average risk, we complete that every 10 years. CT colonography is another option that we do every 5 years in certain circumstances. One important caveat to doing CT colonography, or choosing that, is that the patient still needs a preparation. That's a common misconception when sometimes patients think about undergoing a CT scan, but important to review that. And then there's flexible sigmoidoscopy, either alone or then paired with a fecal immunohistochemical test. I'd say that those last two have fallen out of favor over the last several years. And we do know that there's a rising incidence in right-sided colon cancer. About a third of colon cancers come from the right-hand side of the colon. And with a flexible sigmoidoscopy, we really are just dedicating the exam to the left colon. So we don't see a whole lot of screening with flexible sigmoidoscopy, although in a lot of societal guidelines, that's still listed as an option. So some of the advantages to stool testing, of course, it's less expensive, and we'll come to a slide that kind of gives some numbers to that effect. It can be offered by any member of the healthcare team, so it doesn't have to just be a physician. It can also be a nurse. There's no bowel prep, and that's probably the biggest upside to most patients. It can also be done at home. They don't need to take time off of work or have a ride or a chauffeur. And then there's, of course, it's non-invasive. So a lot of the risks that we'll talk about preoperatively in terms of pain, bleeding, perforation, we're not going to come across those when we're talking about just obtaining a stool sample, hopefully. Many patients we know do prefer home testing. There's several studies that have looked at this, and it's also important to know that patients also like a choice. So this particular study, colonoscopy or fecal occult blood testing or one of the other was recommended. And for the patients where just colonoscopy was recommended, only 38% were compliant with that recommendation. If fecal occult blood testing was recommended, almost twice that number was likely to comply. And then if a choice was given, then we see an even higher percentage in terms of those that completed the test. So it's important when you're discussing with your patient the modalities, that especially if you're going to select the stool test, that there's the expectation that that's going to be then followed by a colonoscopy should that stool test come back abnormal. And I always just make sure that a patient is kind of mentally prepared for that kind of algorithmic approach. And if there's any hesitation about that, then this is probably not the modality that should be chosen. When it comes to stool-based tests, we kind of talked about some of these already, but the newest kid on the block is going to be the Cologuard study. And again, that was approved around 2014. There's really not a gold standard. I'm sorry that the slide is misleading in that way. There's not really a gold standard when it comes to stool-based options. But I should say that in general, when trying to decide between like guaiac testing, FIT testing, multi-target DNA testing, FIT and something like Cologuard, in my opinion, should replace guaiac due to superior sensitivity and specificity. We also know that guaiac can be affected by dietary changes. So especially if somebody's having a diet that's high in kind of red meats or lamb, that can affect the results, or certain medications too. We know that there are some sophisticated platforms in which the FIT test as well as the Cologuard are read. So it's kind of nice that that's an automated feature, which is less prone to interpretation errors. And then we also know that there are kind of built-in patient participation resources that help with screening that the guaiac test just simply does not offer. So a little bit more about the fecal immunohistochemical test, or this can even apply sometimes to the multi-target DNA test too. But FIT in particular, it can be done with 1 to 2 stool samples. Again, it's performed annually. Cologuard is going to be every 3 years. The pros to this is that, again, no direct risk, sampling at home, inexpensive. We've kind of talked about some of those. But we do know it's also 80% sensitive for detecting cancer. I believe Cologuard is in the ballpark of about 93% sensitive. And then there's also some sensitivity when it comes down to detecting advanced neoplasia or polyps. Some of the cons, however, is that even though there is some degree of sensitivity, it's by no means perfect. In fact, it's fairly poor when it comes to sessile serrated polyps. Once again, we know that particular polyp type can contribute to about a third of colorectal cancers. We need to, again, acknowledge that if this is a positive test, that the expectation then is that we're going to move forward and proceed with colonoscopy as our next step. And this also needs to be done on more of a programmatic standpoint in terms of an annual examination, or again, every 3 years when it comes to Cologuard. So there's kind of more hands-on, I'd say, administrative work that's needed to make sure that that happens. So direct visualization testing, again, a lot of options. I think not a lot of people are aware that there are so many options, but the gold standard at the end of the day is colonoscopy. In average risk patients, again, every 10 years is how frequently we would perform that. A big advantage is that if I find a polyp along the way, we're going to remove that at the same visit as long as it's safe to do so. Some of the disadvantages, again, most are going to be familiar with the risks involved with sedation, complications with bleeding or perforations, and then there's always the chance that we can miss some lesions as well. The risk for perforation that I always discuss with a patient ahead of our procedures is going to be about 4 in 10,000, and our bleeding risk is 8 in 10,000, and that, of course, can be variable depending on other risk factors, like if somebody's on anticoagulation at the time of the procedure. 3 main components to colonoscopy quality. Obviously, we want to select the right patients. We want to choose the right intervals as well. And that first slide kind of helps us to decide that based on their track record. We want to maximize the bowel prep. This is where I always wish that a patient could kind of be there to see the difference between a high quality exam and one that is poorly prepped, and that goes for other providers as well that don't do endoscopy. There's just a huge difference. And the onus is also on us as gastroenterologists or endoscopists to monitor our own adenoma detection rate to make sure that we're doing the job that we're expected to do by our patients and our colleagues. I will just echo the point that was stated earlier, is that a lot of clinics don't have the capacity, space, resources to provide a colonoscopy to absolutely every age eligible patient. We're always up for that challenge, but there are limitations just in terms of resources. So it's on us as providers to be our patient's best advocate and to try to get them in as soon as we can, or to identify a modality in terms of screening that's going to be right for them. So just in terms of some of the cost differences, colonoscopy, you can expect about $1,000 price tag. Kind of going down the list, something like a CT colonography is about $300. The fecal DNA testing is about $500. And then the fecal occult blood test is, of course, the cheapest option there. And we reviewed some of the pros and cons to that option. And then the frequency, of course, changes, as we've talked about, too, according to which modality that you choose. So nice slide that kind of just overviews some of the things that we've just discussed. So there are some best practice guidelines for increasing colon cancer screening. And so it's important that we recognize what our screening rates are. That is a quality metric, but I still think it's nice for each provider to kind of have that number in their head in terms of where some improvements can be made. So know what your own rate is, be able to make a recommendation to a patient and be able to kind of navigate with them some of the pros and cons that we've discussed. Developing screening policy is nice. So again, that it just makes it more programmatic. Persistence is key. I find that is true with a number of different situations in medicine, but especially when it comes down to adult health maintenance and screening. It's important that we be persistent. And then being able to measure what progress we make and adapt if something is not working is of course, vital too. So the American Cancer Society had a 80% by 2018 goal or program. We are still well shy of that 80% goal for Missouri and really across the United States. I think every single state is below that 80% mark. I think for Missouri, we're around kind of the mid 60s to maybe upper 60s, but we've got plenty of room for improvement. But this program at least uses some evidence-based practices in terms of which provider reminders and client reminders to have been proven to increase screening adherence. It's making sure that, again, the provider knows what screening options are available, and then it kind of goes over some of the nuance in terms of resources and support for those that are underinsured or uninsured, because that does factor into which somebody's going to be a candidate for. So that's a nice program, at least to be aware of. Another program offered through, or at least sponsored by the American Cancer Society, is going to be the Flu Fit program. So at the time that somebody gets their annual flu shot, pairing that with a FIT test is kind of a nice way to capture patients that maybe otherwise would not be adherent to that guideline or have trouble remembering the annual test or to get any test done for that matter. But it can be easily something that's kind of plugged into your clinic flow. So another nice thing to be aware of, and there is more information available through the American Cancer Society. There's toolkits that are available too. Again, this is another ACS resource, but again, it's designed for a variety of different practices. It looks at what some of the strategies and sustainability models are, as well as some payment factors. And it's really aimed at a couple of different things, but one of the nice things it does is to help reduce some health disparities. Everybody's practice mix is going to be a little bit different. It does involve a team-based approach, so it's not just one individual navigator. It's really your whole infrastructure that's involved in this model, and then it's going to promote again just a system-level coordination. So yet another resource to look at, but an important one. And I believe this is my last slide, but there's some replication manuals too. So you don't need to come up with something, on your own. There are some models that have been proven to work well. One of those is the New Hampshire Colorectal Cancer Screening Program. This is really a step-by-step instruction kind of manual model so that you can implement some of the same things that worked for that model into your own clinic. Patients were about 11 times more likely to complete a colonoscopy than those that were non-navigated in this type of program. So there's abundance of resources out there, and I encourage that if this is something that would be of value to you or your clinic to check these resources out. And with that, I know that we're happy to answer any questions you have, but we're truly grateful to have the opportunity to talk to you this afternoon.